Could I ask you all to take your seats in the interest of time? We're running a bit late. Thank you, everyone. It's been a fantastic day, hasn't it? Full of wonderful speakers, but may I say that I think we may have saved the best till last, because that's my preference. I'm hugely excited and honoured to introduce our guest speaker today. He doesn't really need much introduction. Everyone knows Professor Arthur Wilde. I think, Arthur, you started the first cardiogenetic clinic in the Amsterdam Heart Centre, now internationally renowned. Since that time, it's built and built. You've taken part in numerous guidelines, written many fantastic papers. I think you're still the coordinator for the European reference networks, and greatly took part in putting together the CPPT International Registry, amongst other things. But I think most of us, admire you for your intellect, but also your wise and considered and very patient counsel. So I'm delighted to ask you to come up and give the guest lecture and explain to us what you feel about the sodium channel. Thank you very much. Arthur Wilde.
Thank you very much, and for this kind words, and for Rachel for inviting me to come to London. At this time of the year, it's actually a big pleasure to come to London. And I will not speak about the European reference networks that you unfortunately had to leave 3 years ago. That I know that was not your choice, but that was in your country's choice. So the spectrum of sodium channel disease is, of course, one of the very interesting parts of the inherited cardiac conditions, and I will, on your invitation, speak with that with pleasure. So the sodium channel is a protein in the membrane, circular membrane of the heart, and it's 4 different domains that are if you fold them together, in the lower picture here, if you fold it together, it's like this, and there is a pore in the middle here, and that's where the sodium ions go from the outside to the inside to depolarize the cells. The sodium channel has several subunits that impact on the function of the sodium channel, and it has many binding sites of different proteins that also influence the function of the sodium channel. And by all these different interacting proteins and these subunits, you can already predict how complex this whole system is and how many different phenotypes and how penetrance and whatever you have in our conditions is influenced. So the first disease is to be linked, to be associated with the sodium channel was long QT syndrome type 3, several variants in the early days already, which is 25 years ago. Rugada syndrome at the late 90s was linked to the sodium channel, isolated conduction disease, and also very early already atrial standstill. I start with the long QT type 3. That was the first one, and that appeared to be a gain of function of the sodium channel. And the gain of function, you need a gain of function during the plateau phase of the action potential, so that is not the early influx of sodium, but as indicated here, this is the peak sodium current that is responsible for the depolarization. But during the plateau phase, there is a continuous increased sodium current, and that leads to extra depolarizing current over the plateau phase of the action potential that will prolong the action potential. And that can be caused by different changes in kinetics of the heart. Essentially, it comes down that you need a window current, so extra current either during the whole plateau phase or during a particular part of the plateau phase. So changes in kinetics of the sodium channel lead to an increased sodium current, and they are responsible for a gain of function. And a gain of function, if you have the ST segment here, a simplistic way, ST segment there is an ST segment because action potential repolarization is different in the heart. If it would all be at the same time, the T wave would be as the QRS complex, a very fast beat, but because there is a gradual change in repolarization, you have the T wave. And if you prolong the action potential duration, in this case by the sustained sodium inward current, you have a longer action potential. So a typical EKG of a young male patient with long QT syndrome type 3 is this EKG. The typical, and we don't know why that is actually, but the typical ST segments are, you have a relatively isoelectric part of the initial ST segment and a very brief T wave that is obviously prolonged. So here it's very clear V6, relatively stable, and then a very narrow T wave. Now, why is genetic information important in long QT syndrome type 3? Of course, to establish a diagnosis. A normal EKG does not exclude being a carrier of a variant. With that, you can start pre-symptomatic treatment. It is important for risk stratification. Different variants have different risk. And it's even important for gene-specific treatment within the sodium channel itself. I'll give you one example here. These are two important sodium channel variants that were identified actually quite early. The delta KPQ is the classic one. And you can see that the risk for this particular variant is much higher than for the other variant. And gene-specific treatment is also relevant here because this one responds very well to flecainide, for example, and this one you get cases of Brugada syndrome with flecainide. The largest study still is this one that I was happy to chair. This was the long QT registry that was based on the data from Dr. Schwartz and Dr. Moss. And the LQT3 patients were analyzed in this paper. We had 391 long QT syndrome type 3 patients, and patients with a double variant were excluded. And patients, that's also important, and that is part of the explanation why the data in the literature reported in the literature is different. Patients who were symptomatic before the age of 1 are excluded in this study. And the reason to do so is because these patients are severely affected, and whatever you do, they will have breakthrough events. And then you come up with the conclusion that beta blocker is not effective, or whatever you try is not effective, because they keep having symptoms, and they may even die on maximum therapy. So we excluded them in this particular study. This is the event rate in this group of patients. The lower two are sudden cardiac death and aborted cardiac arrest and sudden death, that is in red. And if you add syncope, you see that about 40% of patients in the end, by the age of 40, do become symptomatic. The risk of sudden death is also significant. It's 15% or 80% if you add aborted cardiac arrest. Females seems to be at a little higher risk than males, particularly at later ages. And as in all the other long QT syndrome subtypes, the longer the QTC itself, the higher the risk of having symptoms. But also in the group, and that is important, the group with a normal QTC, there still is an event rate of 20 to 25% by the age of 40. When we switch to Brugada syndrome, then this is a typical EKG of a 35-year-old male who was resuscitated and presented with this EKG. You see the right precordial ST segment elevation. But if you look carefully, you also see that there is conduction disease at every level. There is an axis deviation, the QRS is a bit wide, the PR is a bit wide, and that all fits with a loss of function sodium channel disease, because that is what the mechanism is in Brugada syndrome. So now there is a decrease of the peak current, which is responsible for conduction, and that decrease in peak current is either brought about by difference in kinetics of the channel. So if you have reduced availability, if the channel activates later, it will lead ultimately to reduction in peak current, or when it inactivates earlier, then it will also lead to a decreased peak current. But for the loss of function, there are many more mechanisms, and that mainly relate to trafficking. So if the protein folding or trafficking is involved, even translation or transcription is involved, that all can lead to a decrease in function, so loss of function of the sodium channel. Genetic information in loss of function, in Brugada syndrome here in particular, is not important for establishment of the diagnosis, because here the diagnosis Brugada syndrome is a clinical diagnosis based on the EKG and not on the presence of a sodium channel variant. So we don't usually start pre-symptomatic treatment. Risk stratification has for a long time, and I will show in the next few slides why that is, has for a long time been regarded as not important in Brugada syndrome, whether or not the sodium channel variant was present, but now I'm convinced it is, based on rather recent data. And at this moment, there's no gene-specific treatment in Brugada syndrome. So the paper that changed this concept of the presence of an SCN5A variant as a risk factor is this paper, this Japanese paper, where they functionally analyzed all the SCN5A variants that they identified. And that is quite a laborious study. So this is the first paper. If you just subdivide SCN5A patients, Brugada syndrome patients, with an SCN5A variant in red, without the variant in blue, then you see there is a small difference. SCN5A patients have a little higher risk for on cardiac events over time. But if you do the functional studies and then discriminate the variants that have proven loss of function and variants that have not proven loss of function, then you see that the difference becomes much marked. So you need a loss of function variant if you have proven it's a loss of function variant, and that is not every missense variant you identify in a Brugada syndrome patient. It becomes very clear that there is a clear difference. We wrote an editorial to this paper, and that is that function, measuring function in Brugada syndrome is apparently more important than all the bioinformatics that are generally used to determine whether variant is pathogenic or not. And this is all the data from the literature. If you already take into account the ACMG criteria, so in the early days there was no ACMG, and the presence of an SCN5A variant was never predictive for cardiac events in all these early studies, and also early meta-analysis summarizing these studies, there was obviously no effect. But if you go to the later studies, and the later studies using the ACMG criteria, and that's already enhancing the chance that you include variants that are non-significant, you already get some signal here. But the signal really becomes important if you prove that the variant is pathogenic or not. Like in this one, you prove that there is a loss of function variant versus others, or where you are in a poor or non-poor. Only there you do get clear information that the variants, SCN5A variants, are important. So SCN5A variants with proven loss of function carry a higher risk in Brugada syndrome than patients without them. Now, what does it actually mean if you, how often does a variant, how often is a variant pathogenic and has proven effect? This is a study from Nashville, from Dan Rodin's group, Andrew Glazer. He studied in a high throughput system 83 variants, and that included 63 with suspected Brugada syndrome associated variants, and reclassified these variants. That was their output parameter. And this is the data of the study. Before the study, 61 of them were classified as a VUS, 10 were likely pathogenic or pathogenic, and 2 were likely benign. And then if you do the functional study, you see that from these likely pathogenic, 9 become pathogenic, 1 remains in that category. But the main difference is here. If you have a VUS that shows clear loss of function characteristics, then you can upgrade that variant to likely pathogenic. If it stays there, that's a minority, and some are even put back into the benign category, non-benign category. So you can conclude from this that functional data apparently are key for correct interpretation of the effect. Now, the sodium channel variants were classically subdivided into gain of function, as I've mentioned, long QT type 3, loss of function, Brugada syndrome, and loss of function, progressive cardiac conduction disease. These are probably more closer to each other than depicted here, but there was a clear differentiation between gain of function and loss of function. But if you look carefully to the clinical characteristics of these different disease entities, LQT3, Brugada syndrome, and progressive cardiac conduction disease, then a prolonged QT interval by definition is present in the long QT cohort. But there are quite a few patients with Brugada syndrome that also have some minor prolongation of the QT interval. Opposite, prolonged conduction intervals are of course present here, but are also present, as shown in the example, in Brugada syndrome. And if your cohort of LQT3 patients is large enough, and they have done that, for example, for the Delta KPQ variant, then you see that the carriers of the LQT3 mutation always have a little longer PR interval, a little wider QS width than the individuals without the variant. Sudden death during sleep is a common event in LQT3 and in Brugada syndrome. ST segment elevation on baseline is the hallmark of Brugada syndrome, but if you challenge individuals with LQT3 with flecainide or ashmeline, then you see quite a few patients, actually quite many, that develop the ST segment elevation that is typical for Brugada syndrome. So I believe the concept should be more like this. These are not separate disease entities. LQT3, Brugada syndrome, and progressive cardiac conduction disease are more closer to each other than initially anticipated. And right in the middle here are some very interesting variants. The 1795 insertion D was one of the variants that we identified, and I'll show you some data on that. But also this variant on position 1784 is a classical overlap syndrome variant. And I think you can actually ask the question whether not every gain of function sodium channel neuropathy is an overlap syndrome. And actually, I believe it is. It just depends how large your family is. If you have two individuals with LQT3 and no overt conduction disease, then you think it's pure LQT3. But if that family is larger with 10, 15 individuals, then you always will find one or two with prolonged intervals. And if you group them all, they have a longer PR interval than their siblings that don't carry the variant. So every gain of function sodium channel variant has some loss of function variant as well, and that probably relates to expression of that mutant allele. Now, this large family that we described in 1999 was a 8th-generation pedigree with sudden nocturnal death, with bradycardia, with QT prolongation that was typically as an LQT3 bradycardia dependent, and with ST segment elevation over the right precordium and conduction disturbances in all compartments. This is the pedigree, and by the time we really dived into it, there were already 25 young sudden deaths, of which 17 nocturnal. And that is not because it was not recognized as of course, this family came together when you were able to connect the different families, because initially they were just separate families. We identified this variant in this pedigree, and this is an example of a 32-year-old asymptomatic male. This is baseline EKG, where you will recognize the QT prolongation, the bradycardia, the QT prolongation. And then if you look at the right precordial leads, there is some hint of Brugada pattern. At that time, we did the challenge with prokinamide, and then you see that there is clear ST segment elevation. This is a 2-year-old male in the same family with a baseline EKG here at the left, and with an EKG during fever here, and you clearly see the pronounced ST segment elevation in the right precordial leads. So a lot of functional data were obtained in this family, and the biophysical properties were that there is persistent inward current, which is responsible for the LQT3 part of the phenotype. It destabilizes fast inactivation, which leads to persistent inward current. It promotes slow inactivation, and that is a loss of function. That's also a gain of function, but it has reduced expression, and that clearly associates with loss of function. Now, in general, the sodium channel opathies have incomplete penetrance, they have variable expressions, and the reason for that is that there are many modifiers, and the modifiers are gender, age, and genes, and I will show examples for all of these. First of all, gender. This is a pedigree from a French family from Nantes, and the family shows conduction disease. As showed at the left, this is lead V2, and it shows, and that is in the symbols that are like this, and if you have solid symbols, the EKG in V2 is like this. So this is clearly Brugada pattern, and this is clearly conduction disease pattern. And then if you subdivide this by sex, then the individuals that have the conduction pattern all seems to be female, and the individuals who have this Brugada pattern, 4 out of 7 were males. So gender is a clear, clearly has impact on whether the phenotype of this same variant leads to conduction disease or whether it leads to ST segment elevation. And that's known because males, if you look in Brugada syndrome cohorts, it's always 80% males. H is another variant. This is another family from Nantes, and here what they did here is they just looked at age on the x-axis and the PR interval and the QRS interval on the y-axis, and you clearly see that also in controls there is some increase in conduction intervals, as we know, but particularly in the carriers of the variant there is a marked increase in PR over while aging, and the same is for the QRS width. So age impacts on these parameters as well. We were also able to show that for this overlap syndrome. The interesting part of this family, of course, is that it has both Brugada syndrome and long QT syndrome. And in this study with the pediatric cardiologist from Groningen, we studied 36 carriers between age 0 and age 16. And we compared them with 46 non-carrier siblings. And we looked at the EKGs. And we know in this family that pacemaker implantation is protective against sudden death, so and you cannot judge the QRS anymore after the pacemaker implantation, so we stopped at the moment of pacemaker implantation. And the data are here, and what you can see here is that the QT interval is different between carriers and non-carriers in every age group, so also in the very young, and it becomes more pronounced when they get older. But the QRS width is similar over the first 5 years of age, and then only becomes different after age 5. So between the age, in this age group 5 to 8 is the first manifestation of QRS width, and over time that stays different. So what we showed in this family, that age-dependent onset of different characteristics. There is immediate QT prolongation immediately after birth. There's almost immediate QRS widening, and the right precordial, that was not in the previous slide, is even later, develops later. Age-related conduction slowing has also been shown in mouse models. This, I'm not showing the data now, but mouse models clearly show conduction slowing over age. And in this mouse model, which you cannot do in humans, obviously, is that they showed the development of myocardial fibrosis, and that probably is the reason that conduction slowing increases over age. This is an example from our group where a sodium channel variant co-segregates with a rare connexin 40 variant, and connexin 40 is a gene that only expresses in the atrium. And if you have the combination of the two, you only have an atrial phenotype, and that is atrial standstill. This is the example. This is, I think it was an adult 30-year-old female with clear atrial standstill, and she has the combination of a loss of subfunction sodium channel variant and this connexin 40 variant, and then you only have an atrial phenotype. Different polymorphisms, even in the sodium channel itself, have an impact on LQT3 variants in this case. This is a very common variant in SCN5A on position 558, and it has been shown in nice studies that when you have both, and the variant and this polymorphism, that you don't have the gating effect that leads to the LQT3 variant. And what makes it even more complicated is this study from Nantes. This is a mouse study in an SCN5A plus minus model. So this is a haploinsufficient model. And so you have 50% of expression, and the expression of the normal allele, of the wild type allele, actually correlates with the penetrance of the cardiac conduction. So here's the summary graph. This is the wild type. This is the a mouse with a mild phenotype, and these are the mouse with a severe phenotype. That cannot be due to the mutant, because the mutant leads to non-functioning allele, so that has to be due to the expression of the, and that's what they show here. They show the expression of the sodium channel protein, and the expression of the wild type allele then modifies the phenotype. So there are a number of other diseases related to the cardiac sodium channel: atrial fibrillation, particularly in young individuals, dilated cardiomyopathy, and this very intriguing phenotype of MEPPC, which all started with this particular variant. Now, I'll be brief on atrial fibrillation and dilated cardiomyopathy. I don't think we really understand why this leads, sodium channel variants, loss of function sodium channel variants lead to these phenotypes. I think it is mainly related to fibrosis, but I have no proof for that, but it's at least, it could be a reason why you have both atrial fibrillation and dilated cardiomyopathy, and they often go together. So patients with dilated cardiomyopathy often have atrial fibrillation. Or it are additional variants, but I have no data to show that. So this is an interesting phenotype, the multifocal ectopic Purkinje-related premature contraction, MEPPC. And the typical EKG is this one. These individuals come with this type of EKG. They are quite often asymptomatic. And what you see here is a normal complex, but there are as many ectopic beats as there are normal beats, and that's very usual, and during the whole Holter recording very often. And one of the interesting features of the ectopic beats is that they are quite narrow, and that suggests the involvement of the conduction system. The group in Nantes mapped these ectopic beats, and this is what they show here. And it actually follows the conduction system both to the left and to the right side. Other groups, group in Australia here, found the very same variant, and they found a very high arrhythmia burden, and also a relation to dilated cardiomyopathy. And they were also able to show that if you treat this particular disorder, and you can treat it very well with flecainide or with quinidine, then the dilated cardiomyopathy resolves completely. And this is not, and unfortunately many of these patients have gone through a long delay for the correct diagnosis, have undergone ablation and multiple ablations, but you can imagine if you start ablating all these areas that there will be no conduction system left in the end. So that's not the way to go. These patients need to be treated with either flecainide or with quinidine. The biophysical properties of these variants, it's a net gain of function of the sodium channel because there is an activation curve shifted to the left, and that leads to an increase in window current. And the big question then, of course, is why is this not an LQT3 phenotype? And that is actually unknown. My personal interpretation of these data is that the Purkinje fiber reposition is at a higher level than a ventricular fiber reposition. So if you have an increased current at a different voltage level, you may exclusively impact on the Purkinje fiber action potential duration and not on the ventricular fiber action potential duration. But that is a hypothetical explanation. I have no proof for it, but the characteristics are quite similar to LQT3 characteristics, but there is no LQT3. So it must be exclusively in the Purkinje fibers. So we can conclude here that the sodium channelopathies lead to a myriad of phenotypes. I think some are well understood by now, others are less well. And I haven't touched on the topic that we have to be very careful with mutation calling. The sodium channel is prone to SNP SNPs. 3%, 5% has been reported in black individuals, even 5 to 8%. So many of the missense variants that you find in particular areas, particularly in these interlinker domains, that are not variants with functional consequences. So there are many modifying factors. There are, and among them are gender and age, and there are many modifying SNPs. I've shown one or two of them, and there are modifying genes. So that could be the conclusion of this paper, and we would go home all very happy. We do understand it all, but I'm going to show you an example that we probably don't. And so do we really understand what's going on? And this is a clinical example. This female, 71-year-old, had an out-of-hospital cardiac arrest and no other history. Her QTC is a little long here for 60, and during bradycardia it became even longer. This is the pedigree. Her husband died from another cause, and she had two sons, one born in 1961 and one born in 1964. And the son born in 1961 is here. And you see the QTC is markedly prolonged, 520. And on the right precordial leads, you have the, well, let's say this is a type 3 Brugada pattern. So living in the Netherlands and having this large founder variant with an overlap syndrome, I thought immediately, I've got you. This must be the SCN5A overlap syndrome on this particular variant. So we checked for that, and that was unfortunately not the case. But the good part of the story is that what was the case that he had two variants. And one is a very typical LQT3 variant, as I've shown you earlier. This is the classical one that was first described. And this variant is known to lead to no expression. So you have one variant with no expression, you have one variant with LQT3 characteristics, so that still adds up to overlap syndrome. And now the other brother. This is the brother born in 64. He's 40 years old at the time of this EKG. And this is his EKG. He has a normal QTC, and he has a normal, he doesn't have a normal right precordial leads, particularly in the setting of this family. So almost normal ST elevation in V1, and then the question obviously is, does he have the loss or does he have the gain of function variant? And I bet, at least we had a bet on that he had the loss of function variant because of this EKG characteristics. But lo and behold, he had the gain of function variant. So, do we really understand what's going on? I don't think so, and that fortunately means that we have still a lot of work to do. And with that, I thank you very much for your time.
Do we have any questions from the audience? I don't know if I could task someone with a microphone, perhaps. And while we're thinking of questions, Arthur, thank you very much. It's a wonderful talk. I wanted just going back to the gender differences. So the males who had the Brugada pattern and the females with the conduction disease pattern. When you're working up a family where there's a family member who has Brugada and you're doing sodium channel blocker tests, sometimes you may see significant QRS prolongation, but without a type 1 pattern in some family members, and perhaps more so the women, and perhaps that could be the first sign of that conduction disease. And presumably in that situation, obviously you go on and do genetic testing, and a sodium channel variant might help to explain it. I wondered what you thought about when you see significant QRS prolongation during an adrenaline test outside of that context, so without there being an obvious family history of Brugada syndrome. Do you think that there is a sign that there's an underlying sodium channel variant in that individual? Would you think of doing a genetic test? Would you screen other family members first to look to see if there's a Brugada pattern induced with sodium channel blocker?
So I'm a strong proponent of the idea that the Brugada pattern relates to a conduction disorder in the right ventricular outflow tract. epicardial part of the right ventricular outflow tract. And you need fibrosis for that in that particular area. And then if the amount of fibrosis is sufficient, then you can have the type 1 pattern. If it's not sufficient, you can unmask it with a sodium channel blocker because the impulse comes later at that part. And the conduction there is also hampered by the combination of fibrosis and the sodium channel blocker. If you don't have fibrosis at all, and I think that's more frequent in women, then you still do have the effect of the sodium channel blocker on the general conduction parameters, but you don't see the ST segment elevation because there's no substrate in the right ventricular outflow tract. The sodium channel variants that have one of the black boxes at this moment still is why do loss of function sodium channel variants lead to fibrosis at all? And it's not only in the right ventricular outflow tract, it's throughout the heart. There are MRI studies, longitudinal MRI studies that show small changes over time in the wrong direction, pointing to development of fibrosis, I think. We don't really know why sodium channel variants, loss of function sodium channel variants leads to fibrosis. But apparently it does. It does more so in males. I think progesterone is the main to blame here. It's the hormones that is to blame there. And that's why it develops more frequently in male. But having a conduction delay on ashmalin, some people are very sensitive to ashmalin, others are less, and that's what you're asking. We have shown, Rafik Tardos, who worked with us for a couple of years, and is now back in Montreal, showed that the response to I think it was all ashmalin, to the ashmalin test in terms of conduction parameters is directly associated with this polygenic risk score that is used in Brugada syndrome, and that is only the first 3 variants. So the first 3 variants of the first 3 loci that were published in 2013. So 2 on chromosome 3 and 1 on chromosome 6. If you add that as a polygenic risk score and it's high, then you are very sensitive to ashmalin. If it's low, you are not that sensitive to ashmalin. So and these are individuals without a sodium channel variant. So it is a polygenic risk score there, and we haven't repeated that study with the last year published GWAS on where the 22 variants popped up, but it's very logical that you will find a very similar picture there. So it's a polygenic risk score that determines your conduction reserve, and if you challenge that with ashmalin, you are more easily unmasked if your polygenic risk score is high. But that not necessarily leads to a Brugada pattern because you need some extra for that.
And in terms of managing those patients, would you give them the same lifestyle advice that you'd give to a patient with a inducible type 1?
That's a difficult question, and I think they are less at risk than a patient. So the arrhythmogenic substrate is not the conduction delay per se in the heart, but it's the substrate in the right ventricular outflow tract. And so if you don't have that, you are significantly less at risk. I still would be careful with sodium channel blockers, and probably also I would at least advise them to make an EKG with fever, but I expect that not much will happen there.
Thank you.
Yeah.
Stephen.
I was going to ask a very similar question actually about how you manage conduction disease in these overlap families, which you've clearly described, and whether you give them long QT advice and Brugada advice or neither. And do you treat their conduction system disease as you would any other patient with conduction disease, or is it more malignant? Do you have a lower threshold for device therapy?
I think if it's only conduction disease without ST elevation, that's what I already addressed. I think that's not a very malignant disorder. If it comes with QT prolongation, that is the overlap family that we described, and in that particular family, it was very clear that a pacemaker therapy in itself is sufficient. The pacemaker avoids long pauses, so avoids the QT prolongation. And the Brugada pattern is also less with faster rate. So we have treated them with pacemakers for a long time, because that's what they used to do. And the family was originally described in Groningen, and they implanted pacemaker already shortly after birth. Based on the data that I showed, we could demonstrate that you don't need to be so early. You can wait until age 10 or 12 before you implant the pacemaker. But the pacemaker, everyone who was on pacemaker therapy survived, and everyone who refused the pacemaker or was not known with the disease some of them died suddenly. In later years, we did that same analysis 15 years later, and then we found out that the few individuals with a pacemaker died at older age, and the common denominator in these individuals was hypertension. And then we have a mouse model of the same mutation, and so we challenged the mice with hypertension by aortic bending, and we found out that these mice died suddenly after. So hypertension apparently is an important modulator. And so our treatment now is that we still implant pacemakers as prophylactic, but at the moment they develop hypertension over time. We are aggressive with hypertension treatment, but if they still develop hypertension, and particularly myocardial hypertrophy, we change the pacemaker into an ICD because we consider their risk. They are no longer protected with the pacemaker alone. Now, this holds for this particular overlap family. Whether the same is true for any other overlap family, I don't know. Probably yes, because the mechanism of the hypertrophy is also influenced by the calcium homeostasis that is different. Because of these long action potentials, you have more entry of calcium, and that leads to different changes as well. And so probably all the other overlap syndrome variants act differently, but we have shown it for one, and I'm not 100% sure whether you can extrapolate that to the others.
I have a question, Arthur. We rarely see long QT3. It's quite unusual. Don't really see too much Brugada in children. You don't see, you get one or two. But the very typical time that an SCN5A presents to us is a teenager, and they have sick sinus, and then they have atrial tachycardia or atrial flutter.
Oh.
And so you are usually in a situation where you have to put a device in, and there's always the question in my head, should I be putting a pacemaker in or an ICD? What would you advise there?
And they have a clear type 1 pattern.
So they present with sick sinus, long pauses usually.
Oh.
We have a whole series of them, I don't know.
Oh.
And so you think, right, I've got to pace. And they usually have an atrial arrhythmia, not a ventricular arrhythmia.
Yeah.
And then it comes back as an SCN5A, and you're
so
just worried as to what device I should be putting in.
Well, these patients have clearly an atrial phenotype. That's due to the very same SCN5A variant that may lead to fibrosis in the ventricles or in the conduction system, can also lead to fibrosis in the atrium. And when there is an exclusive atrial phenotype, we have at least one family where we can demonstrate why that is. That is that connexin 40 variant. I expect that to be present in individuals with a pathogenic loss of function SCN5A variant with an exclusive atrial phenotype as well. So if they don't have a clear type 1 pattern on their EKG, then I would stick to a pacemaker and then, of course, follow them over time. And later in life, they might develop more ST segment elevation in the right precordial leads, and then probably you have to change to defibrillator, but that can be 20 years later, and that is a lot of saved time for these thick ICD leads that are not in their vascular system for 20 years.
Greg, I don't know if we can get you a microphone, Greg.
Arthur, given the variable expressivity, how do you approach a family member who's had predicted genetic testing, has a sodium channel variant, and you're assessing them for the first time?
And then with or without a phenotype?
Well, they've come to you with a positive genetic test, they've not had any cardiac tests at all yet.
And we are discussing the loss of function phenotype, I suppose. Yeah. So that is prone to Brugada syndrome. What we do is we make an EKG, obviously. We make an EKG with the higher placed leads. And there we stop. We do an exercise test, we do an Holter, but we don't do the Ashmolean test. And I think the Ashmolean test is a dangerous procedure in an individual with a loss of function sodium channel variant. The literature is clear on that. It's not a very high risk, but if a patient deteriorates with malignant ventricular arrhythmias, then it's always a patient with a loss of function sodium channel variant. And if there is no ST elevation at baseline, I don't think the risk is higher if you prove that there is a ST elevation with Ashmolean. So we follow the patient over time. If they are young, they might well develop it over time. My personal belief is that you need the development of fibrosis over time. And then the situation may become different, but there's no need to challenge a young individual, asymptomatic young individual with a sodium channel variant with an Ashmolean test, because your management is not different. You will get the lifestyle advices. We always advise them to come back at least once with fever. And then if the fever has a normal EKG, you can stay away with the next fever episode. But in 5 years, things may change. So that type of approach is what we take.
I'll go for another question then. So I know you haven't touched on risk stratification in Brugada syndrome, which is sort of well known to be very challenging. The 3 patients that I've taken to the cath lab to do substrate modification in Brugada syndrome, who've all had recurrent VF and cardiac arrests, none of them had a spontaneous type 1, none of them had had previous syncope, and my concern, and they're my 3 most malignant phenotypes of the 160 Brugadas in our cohort. Can you sort of postulate why that might be? Why my most malignant patients seemingly the lowest risk?
So that means that they have no baseline ST segment elevation, also not in the elevated leads, and that is on repeated EKGs, I suppose. Because quite a few of these patients may have an EKG without the ST segment elevation, and the next week that might be pronounced ST segment. And that actually is a risk factor. If you have a very variable ST segment elevation shifts, that is a risk factor in itself. I have no clear clue, but and is there conduction disease? And was there SCN5A involved? Do you know?
In one of them there was. The other 2 they were negative.
Yeah, I don't know. That's a discussion. If you speak with Papone about it, Papone prefers to take anyone into the cath lab and do the ablation and implant the defibrillator, whether they have symptoms or not. He tells you that the absence of ST segment elevation does not at all predict how large the substrate is. I don't. That might be true for an individual patient, and your patients may be examples of that. But overall, the individual with a drug-induced ST segment pattern has a way lower risk than an individual with a spontaneous type 1 pattern. So that must mean that the absence of a spontaneous type 1 pattern is a lower risk than if you can only induce it with drugs. They also show that in general the substrate in patients who do have a type 1, that the substrate they can measure is larger, much larger than if there is no spontaneous type 1. And if there's no spontaneous type 1 and you have a given size of the substrate, you enlarge it with Ashmolean. So the size of the substrate is probably what determines the risk. There has no study been yet where that has been shown in a nice way, and definitely not in a prospective way. Papone is working on it, but he has in the meantime 1,500, 2,000 individuals who have undergone ablation in his center, so he has all these data. But many of these individuals are asymptomatic and don't have a spontaneous type 1, and I'm one of those who really doubt whether that is ethical to put all these patients into that procedure. In the hands of Papone, an epicardial approach is probably very low risk because he's extremely experienced. But if we're going to ablate all the patients with Brugada syndrome, asymptomatic Brugada syndrome, and every one of us is doing, then the complication rate will not be insignificant, I presume. And these patients are at low risk, so there is a balance between the risk of the procedure and the risk that the patient has to start with. I do believe that there will be a point that the symptomatic individuals with a type 1 will undergo ablation primarily and then probably don't need an ICD. That I think we need a trial for that, a randomized trial, and we need a particular because of the event rate that is caused by the procedure itself. And because of the Ashmalin, because these individuals many of them will have a SCN5A variant, and you have to expose them to Ashmalin in the cath lab, and also in the lab in Milan, there are individuals who end up in an arrhythmic storm and on an ECMO because of the arrhythmias they induce. So you need to have a randomized trial, but I won't be surprised that it will be something similar in the future than WPW syndrome. If you ablate the delta wave, you're cured, and that might happen with Brugada syndrome too. But we first need that trial. That's not an answer to your question. I don't know why these three individuals are.
Shall I read it? We've got a question that's come in from the online audience. It said, does fibrosis in the RVOT progress with time? If so, and a patient has a negative Ashmalin challenge with a family history of gene-negative Brugada, should we consider repeating it every decade as an adult?
Yeah, so that is certainly the case when they are very young. If you challenge a young boys, I think in particular, before puberty, you won't see many Ashmalin tests are negative, and after puberty, they become positive. I also think that will be the case over time, because if we postulate that fibrosis develops over time, then the substrate develops over time. Quite often you see spontaneous appearance of, but if you don't, then you probably have Ashmalin to challenge it. And I wouldn't be surprised if a test is negative at age 25 and positive at age 35. So that is something we have to find out. Yeah. After the other point of that's also maybe important to make that point, we also know that older Brugada syndrome patients their risk becomes less. And that probably also relates to the fact that if the fibrosis development continues to go on, then at the point in time there's no way for circuits left anymore because everything is fibrotic. And if the whole right ventricular outflow tract is fibrotic, there's no risk for arrhythmias anymore because you don't have these. So that probably underlies the reason that a 60-year-old type 1 pattern has less risk than a 13-year-old.
Are there any more questions? I think.
It's time for a beer, isn't it?
Yeah, no,
Yeah.
Thank you very much for a wonderful talk.
So I think we just have one or two more things before closing the meeting. I know everyone's got to get away.
I'm conscious the pub is calling, so we'll be very quick. Just a couple of quick presentations. So we had some wonderful clinical cases and scientific abstracts. So we've got some awards. I think these are the first checks from your new checkbook, aren't they, looking at the numbers? So, yeah. So for the first award, the best clinical case presentation to Nicholas Checks. Fantastic. So a large cheque, so follow him to the pub, I'd suggest. Great. And then the best scientific abstract, so Daniel Hammersley. Well done, Daniel. Great. So last couple of things. Big thank you to everyone for coming. It's one of the most enjoyable conferences I think I've been at for many, many years. And the quality of the program and the speakers was just absolutely incredible. So on that note, just a couple of quick thank yous. So to the people, that it's a huge amount of work to do this. To set it up is a huge amount of work. To set it up with this quality of a program is incredible. So a big thank you to Eleanor. Thank you so much for that. And I'd like to point out these are from Steve's cellar. So thank you, Steve. And last and definitely not least, a massive thank you to Rachel. Thank you very much, Rachel. And your husband will be very pleased with the present, won't he? So yes, thank you very much. Great. Thank you all for coming. And I think, anything else you want to say, Rachel? No. Great. Well, thank you all. See you next year, I hope.